Hi everyone, my name is Samantha. I'm a fourth year student at BCom in Blacksburg, Virginia, and I'll be talking about Heyde syndrome and COVID-induced hypercoagulability. So Heyde syndrome is a triad that consists of aortic stenosis, angiodysplasia, and acquired von Willebrand disease. And the pathophysiology behind it is still under discussion, but what it hinges on basically is a shearing mechanism. As the von Willebrand factor passes through that calcified aortic valve, it gets sheared and is dysfunctional. Definitive treatment is valve replacement of that aortic valve that stops the shearing process. Those with Heyde syndrome are at a risk of bleeding due to acquired von Willebrand disease. And then at the same time, a major complication of COVID-19 is hypercoagulability. So DVTs, PEs, those kinds of things. And the current treatment protocol for a DVT is anticoagulation for 3 to 6 months. Patients over the age of 65 are both more likely to have Heyde syndrome and more likely to suffer from VTE as a result of COVID-19. So as those two things overlap, these patients are at a greater risk of bleeding complications and would benefit basically of a greater understanding of Heyde syndrome and consideration of it as a differential. So our patient is an 81-year-old female. She had a history of chronic respiratory failure, heart failure. She came in with 2 to 3 weeks of dizziness, lightheadedness, and weakness, and some shortness of breath over the last day. On exam, she was pale. She had a 4 out of 6 systolic murmur and was on 5 liters of oxygen, up from her baseline of 2 liters. A little bit more background on her. She was diagnosed with COVID pneumonia about 6 weeks prior to this presentation, treated with steroids, and discharged. 2 weeks after that, she came in and she had bilateral tibial DVTs. An echo at that time showed aortic stenosis that was new since 2018. And she was discharged on Eliquis and was taking that for about a month when she came in with her symptoms of the dizziness and lightheadedness. On presentation, her vitals were stable, but her hemoglobin was 5.5, and she had a positive FOBT. Her chest x-ray was concerning for some atypical pneumonia. Her EKG was unchanged. So her initial treatment course was azithromycin, some fluids, and 2 units of blood. She had an EGD with GI that showed suspected angiodysplasia as a source of bleeding. And she had 2 additional episodes of symptomatic anemia during her hospitalization that were each treated with a unit of blood. A lower extremity ultrasound showed resolution of her DVTs, but hematology recommended an IVC filter if her DVTs did recur because of her bleeding risk. So over the course of her hospitalization, her hemoglobin stabilized, oxygen requirement decreased to baseline, and she was discharged home with close follow-up. So the figure here is a schematic about Heyde syndrome. On the left here, we have normal physiology. So von Willebrand factor circulates in the blood, and its conformation passes through the valve, no problem. Clotting cascade works as normal. On the right here with Heyde syndrome, as von Willebrand factor passes through that calcified stenotic aortic valve, it gets sheared, conformation changes happen, and the binding site for the ADAMTS13 protein is opened up to it, and so it can be cleaved at that point and becomes dysfunctional, and that really leads to the bleeding complications. So this patient came in with the new aortic stenosis and gastrointestinal bleeding that GI thought was due to angiodysplasia, which is really why we considered Heyde syndrome. And further workup would include identifying that acquired von Willebrand disease. So doing that through a platelet function assay or von Willebrand multimer assay, where you would see decreased high molecular weight multimers. And with this patient in particular, there was a discussion with her and her family and the care team, and it was decided because she was not a good surgical candidate because of her chronic respiratory failure that we would not initiate the workup because her treatment options really wouldn't change. So that was kind of the thought process behind that, but it was a discussion that we had. So why does this matter in general? Increased COVID-19 incidence is leading to increased sequelae, increased hypercoagulability, more DVTs, more patients on anticoagulation to treat those DVTs, and then the possibility of more patients having manifestations of Heyde syndrome, basically having Heyde syndrome unmasked by their anticoagulation. And so because there is a treatment option that comes up, aortic valve replacement, the identification of Hyde syndrome can really change treatment plans and change outcomes for these patients in the long term. And so especially because that patient population over the age of 65 is susceptible to COVID complications, undiagnosed Hyde syndrome, it's really important moving forward to characterize Hyde syndrome, think about it, consider it on your differential, because it can really change treatment outcomes for these patients. Thank you.
Are there any questions from the audience? So ultimately, did this patient receive an IVC filter or did she not?
She did not. And last I checked, when I looked into her chart, she hadn't had any further bleeding episodes. That was about probably a couple months ago, but since then she's been doing well.
Do you think COVID-19 can cause an increased risk of, Heyde syndrome? Does that the sequelae, can that kind of come up more frequently in patients with COVID?
I don't know if it's so much a cause as something that can overlap with it and really unmask Hyde syndrome. Like if someone has Hyde syndrome, they can go throughout life maybe without manifestations. But if they have COVID, especially with those hypercoagulability complications, then I think in those populations there would be a higher incidence of people having those manifestations and having the bleeding problems and things like that from the Hyde syndrome that maybe they didn't know they had.
All right, wonderful. Any final questions from the audience? All right, thank you so much.